very hard to summarize in a short amount of time, but we now have very deep understanding of the cell types that make fibrosis in liver. Primarily, it is the hepatic stellate cell, which becomes activated and turns into an activated myofibroblast in chronic liver disease. And myofibroblasts are the major target of antifibrotic therapies, and that's a major advance. We also know the source of the fibroblasts, myofibroblasts, in other forms of liver disease, such as biliary fibrosis. We know the mediators that drive activation of myofibroblasts, and most recently, we've learned a lot of information about the heterogeneity of activated myofibroblasts based on very elegant studies using single-cell RNA sequencing. So we really have a very deep and comprehensive understanding of stellate cell biology, and that really forms the basis of clarifying the role of fibrosis. At the same time, we are also learning more about the signals that drive fibrosis that emanate from hepatocytes, inflammatory cells, and other resident liver cells, including sinusoidal endothelial cells. So we continue to gather a very comprehensive picture of both the signals and the cell types that drive hepatic fibrosis. The hepatic stellate cell certainly is in the center of pathogenesis of fibrosis, not so much when it is quiescent, but when it becomes activated. It becomes a source of extracellular matrix proteins, as well as inflammatory and fibrogenic mediators that influence other stellate cells and also talk to surrounding cells, in particular sinusoidal endothelium. So stellate cells are absolutely at the center of the dynamic of liver fibrosis. In terms of molecular markers, there's a lot of activity and a lot of progress. So far, we do not yet have a marker that can replace biopsy for clinical trials, but we're getting closer. Starting with blood tests, we have some well-known blood tests such as the FIB4, the ELF marker, ProC3, but in addition now there are at least 2 different platforms for measuring aggregate serum proteins called proteomics. So there are now proteomic studies in blood. The other group of diagnostic modalities that's coming quickly improving are imaging tests, particularly MR elastography and MR fat fraction, as well as corrected T1 weighted imaging. All of these imaging tests are becoming much more useful in assessing the severity of liver disease and the amount of fat. There are diagnostic tests now that can measure liver function. One is called HepQuant, which measures the metabolic reserve of the liver. And there are now tests to measure serum proteolytic activity from a company known as Glimpse Bio, GLYMPSE. And finally, when biopsies are performed, there are now a number of artificial intelligence-based methods that can in much more detail measure different components of the biopsy in using different techniques that give a much more comprehensive and quantitative picture of both the cells and the structures within the liver biopsy. So a lot of progress. The hope is that we will be able to avoid doing biopsy altogether to stage disease, and this will be very helpful in accelerating the development of clinical trials. In terms of potential drugs to reverse liver fibrosis, there are probably about 12 drugs that are in phase 3 trials now, another 50 to 60 drugs in phase 2. So a lot of exciting new drugs. None of them have been approved yet. In phase 3, we have FXR agonists, thyroid hormone beta agonists, FGF21, FGF19, in addition to a growing list of PPAR agonists, particularly pan-PPAR agonists like PPAR alpha delta gamma agonists, PPAR delta agonists. I already mentioned FXR agonists. And then on the also in phase 3 now is a drug called aramcol that blocks steroid-CoA desaturase 1 and reduces liver fat. In phase 2, there are other drugs to reduce liver fat, such as an ACC inhibitor, a fatty acid synthase inhibitor, and most recently a drug that is going into phase 2B called icosapentate that has exciting ability to improve liver tests and may help in resolving NASH. Beyond that, there are too many drugs for me to actually list altogether, but a lot of excitement, a lot of drugs. We're very, very close. I think within 2 to 3 years, we may see a drug approved for NASH. Certainly, obeticholic acid looked promising, and now the FDA is reviewing the possibility of approving obeticholic acid, which is an FXR agonist. So, that's a short version of what is now a very comprehensive list of potential drugs.